This podcast is brought to you by the Pacific Neuroscience Institute Foundation. Are you looking to support your memory and optimize your quality of life? Develop a healthy brain for brighter days at PNI's Lifestyle Program, available virtually and in person. Reserve your spot today. Visit pacificlifestyle.org to learn more.
Hello, this is Anthony Effinger. I'm the host of the Think Neuro podcast at Pacific Neuroscience Institute. And today I'm talking to Dr. Sandra Narayanan. She's a vascular neurologist and a neurointerventional surgeon at PNI. Dr. Narayanan, thanks for joining us.
Thank you so much for having me, Anthony.
So tell me what those things are.
So I am a stroke neurologist by background, also known as a vascular neurologist. I trained as a neurologist by background, which means I did a internship in internal medicine, and then I did a neurology residency followed by a subspecialty fellowship in stroke neurology. I trained in the specialized care of stroke patients of all kinds, and also in the neurocritical care, the ICU management of these patients. And then following that, I did a fellowship in neurointerventional surgery, also known as interventional neuroradiology or neuroendovascular surgery. And that means the minimally invasive management of patients who have blood vessel disorders of the head, neck, or spine. And oftentimes that means taking care of patients with stroke of all kinds, the clotting kind of stroke, the bleeding kind of stroke, also patients who have aneurysms, other blood vessel disorders, tangles of blood vessels, and that's in the hospital setting, in the clinic setting, and a variety of management options. So
your specialty is blood vessels in the brain.
Brain, neck, and spine. Yes.
Brain, okay. So when people hear stroke, they have a vague idea of what it is, but I don't think people actually really know. Can you tell us what a stroke is?
A stroke is one of two kinds of damaging processes that can either arrest flow to one of the arteries in the head or neck. That can be an ischemic stroke 87% of the time, where there's lack of blood flow or narrowing of the arteries.
And that's caused by what? By
a blockage in the artery or narrowing of the artery and lack of oxygenation to the brain.
And is this where we hear about like plaques blocking arteries?
Right. A plaque can block the artery or a clot can block the artery.
Okay.
And that's an ischemic stroke 87% of the time. Hemorrhagic stroke is when there is bleeding in the brain. A hemorrhagic stroke occurs 13% of the time. And it's, although less common, it is fulminant and extremely damaging when it occurs because it's sudden pressurized release of blood in the brain.
So that's the thing that where, in both cases, time equals brain, right? You have to remedy both of these things and get blood flow and oxygen to the brain, or you start to lose brain cells, correct?
Right. So you do need to act immediately. You do need to activate emergency medical services because in both cases, we don't know what kind of treatment can benefit these patients right away. We know that activating emergency medical services can result in speedier acquisition of neuroimaging, so CT scans, advanced vascular imaging, so blood vessel imaging, for example, CT angiogram to determine if there is a large artery that's blocked in the case of an ischemic stroke to tell us where the blockage is and whether removing the clot in a timely fashion can restore the circulation. And if an emergency procedure, such as a mechanical thrombectomy, which is what neurointerventional surgeons such as myself do in a timely fashion, can benefit that particular patient. Mechanical thrombectomy is a life-saving procedure which is done for patients who have an ischemic stroke in progress from a large artery blockage in the brain or the neck. And many strokes are not due to a large artery blockage. They're due to small vessel blockage. But in the case of a large artery blockage, time is certainly of the essence, because getting that clot out by a procedure such as mechanical thrombectomy is the only life-saving tool that is going to be able to be performed in a time-sensitive procedural fashion that is going to save that person's brain tissue downstream of that blockage.
And how do you do that? Are we going into the artery?
Yes, absolutely. So we thread a small, flexible, hollow catheter through the arteries of either the groin or the wrist under X-ray or fluoroscopic guidance. And navigate with the use of iodinated contrast, so dye, and see exactly where the occlusion is, where the blockage is, and suction or snare out that blockage and restore circulation in a time-sensitive fashion. So we time ourselves, and our regulatory bodies expect us, Emergency Medical Services and American Heart, American Stroke Association, we time ourselves to make sure that we are adhering to national and regional standards to get this out as quickly as possible. On call, we are continuously monitoring calls from our emergency medical colleagues, from pre-hospital notification through EMS, emergency medicine physicians, and then we also use artificial intelligence applications. So there are a few ones commonly in use, such as Rapid AI and Viz, that pop up on our phones and allow us to partner with the PACS systems in use at our local facilities.
What's PACS?
So it's the radiology communication systems that display images electronically as soon as they're acquired by the CT scanners. And so they send over the images in real time, but there are artificial intelligence systems that send via secure applications a algorithm that will let us know whether there's a high likelihood of a large vessel occlusion, and those will precede by several minutes in assessment of whether there's a large vessel occlusion. So we'll be continuously monitoring those in real time, especially if we get a heads up from emergency medical services or the emergency department physician for a particular patient. Hey, this patient has a high likelihood of a large vessel occlusion. Be on alert, have your teams on alert, be ready to come in because we think this person's got a high likelihood of having a large vessel occlusion. They came in not talking and with paralysis on the right side. We're about to push a thrombolytic. So we pair up with the emergency.
Thrombolytic is a...
Thrombolytic is a life-saving medication that is appropriate for a certain percentage of the population who meet certain criteria. And in some patients, particularly those with smaller clots or smaller blockages, it can be sufficient to open up the blockage, and they may not need a thrombectomy. Not all patients qualify for a thrombolytic because you have to meet certain criteria. The onset of stroke either has to be witnessed or has to have occurred in the last 4.5 hours. They can't be on any simultaneous strong blood thinners.
I was going to say, yeah, I bet.
Yeah, because we don't want the bleeding risk to be too high. They can't have had any recent major surgeries, for example, major thoracic surgeries like a coronary artery bypass,
Because of bleeding.
for example, because of bleeding risk.
Is it,
right?
does these thrombolytics just sort of dissolve? Is this like Drano for your arteries, or?
Yeah, that's a good analogy. They dissolve the cross-linking bonds that form in the first minutes to hours after formation and deposition of a clot in smaller or large arteries, because of the way the clots form in the body and so many clotting and anti-clotting factors. Some of the fresh clots that form are susceptible to some of these lytics, these thrombolytics, and they can be very powerful, and they can be very powerfully broken up in the first few minutes to hours. But the longer the clot is and the larger the artery in which the clot has lodged, the lytic may not be sufficient. So knowing that, we don't wait for it to work. Patients that get a lytic and who also have a large vessel occlusion, we don't wait for it to work. We send them straight to the room in which we do these procedures called the angiography suite, assuming that it's not going to work and we're going to be doing the procedure. And then if by any chance their deficits reverse, they start talking, they start moving the paralyzed side, and or they return to normal, we are pleasantly surprised. We can always call off the procedure, but that way we don't lose time.
Why do you hear about strokes with people who've been on airplanes so often?
I think that it makes for an unusual...
Clots. Is it clots or stroke?
I think it can be both.
Okay.
Clots in patients who have been on an airplane can occur by a variety of mechanisms. One is they are forced to remain in cramped conditions, so their legs are not moving. So you can have what's called venous thromboembolism. Venous thrombosis occurs because there's thrombosis is clotting, and venous thrombosis occurs in the veins, typically the long veins of the lower extremities, because the legs are not moving. That's one of the reasons why for long flights, doctors can encourage some patients, particularly those who are prone to venous stasis, so just lack of circulation in the lower extremity veins, for example, diabetics, or those with already predisposition for lower extremity edema or swelling, to get up and move around a little bit and encourage that circulation, especially when it's safe to do so for long flights. So you can have venous thrombosis tendency in long flights. But that increases the risk for the venous circulation, which is typically separate from the arterial circulation. Stroke is an arterial disease, and it's not really never the twain shall meet, because you can have communication between the venous circulation and the arterial circulation if you have a communication between the right and left sides of the heart, and that's called a patent foramen ovale. So it's a communication that typically closes at birth, but it can remain open in a certain population of patients, so through adulthood, and it may never cause an issue. But if there is straining and encouragement of shunting from the right to the left sides of the heart, and there is clotting in the lower extremity or pelvic veins from dehydration or a pro-clotting state, stasis in the lower extremity veins, or lack of movement, for example, patients who have been on a long flight, or patients who are recovering from a surgery and have been bedbound for several days. Anything that increases a sedentary state and lack of circulation in the lower extremities, these are things that can increase the risk of venous thrombosis. So that's one of the mechanisms.
Yeah.
As far as the increased risk of stroke, arterial stroke on long flights, it's hard to know if there's really a one risk for that. I think it's more when it does happen, it gets a lot of attention in the media because it's just an unusual spot to see a stroke.
What should we do? Is there anything we can do to avoid stroke, both kinds of stroke? I know some of it's just anatomy and right, how you're born, right? But what are the things people can do to avoid this?
Right. There was a study that came out recently. It's now actually been a couple of years that demonstrated that up to 80% of the risk factors for stroke are potentially reversible with lifestyle changes. And those can be as simple as being aware of what your own personal risk factors are, as well as taking control of your numbers and taking charge of them. So if you are hypertensive or have
high blood pressure.
Right. If you have high blood pressure, taking charge of those, acquiring a blood pressure machine and taking your numbers every day to know what they are, keeping a log, knowing when you are at risk. So running over normal, which is 140/90 if you are if you have no other major risk factors, or if you have a history of diabetes, then your number should be less than 130/85. If you don't have regular appointments with your primary care provider or cardiologist, whoever is your primary source of healthcare management or your primary healthcare professional, making a regular appointment every 6 to 12 months and monitoring, taking care to make sure that you are on the appropriate management, whether that it's a prophylactic healthcare screening. So monitoring your lipids, monitoring your body mass index. So a lot of people are within the overweight status. So BMI of over 25 and between 25 and 29.9. So that's the overweight category. BMI of 30 and over is obese. So that increases the risk of having metabolic syndrome, which increases the risk of diabetes. And so getting on a healthcare plan to make sure that they're on a weight loss management plan.
And now a message from our sponsor. The Think Neuro podcast is brought to you by Pacific Neuroscience Institute Foundation, a nonprofit 501c3 organization. If you're inspired by what you hear and wish to support our mission of education through innovation, please visit pacificneuro.org/foundation.
These things seem to change so often. Is it still, is butter still evil when it comes to stroke and plaques and cholesterol?
Yeah, I wouldn't say that butter is evil. Honestly, there are a lot of dietary fads that come and go. And I think that everything in moderation is all right, except when it comes to certain substances. I wouldn't say that when it came to certain substances, right? Because even a small amount of illicit substances can land you in the emergency department with a major ischemic hemorrhagic stroke or myocardial infarction. But as far as dietary intake, what we're seeing is that avoiding, extremes is really what we would advocate at this point in time. I direct most of my patients to the website of the American Heart Association, www.heart.org, for a lot of ideas on how to tailor their diet and look at what is their sodium goal. If they are already a hypertensive or looking to cut down your sodium intake, there are a lot of ways that you can get hidden sodium in your diet. And it's pretty easy to get to 2 grams of sodium per day, 2,000 milligrams of sodium.
Because it's in our diets, it's in processed foods, it's in...
Right. Unless especially if you're going out to eat or you're getting taken pretty regularly, it is pretty easy to get to over 2,000 milligrams of sodium per day. So just...
And is that the threshold?
If you are aiming to stay within the daily guidelines for someone who has hypertension. That's what we recommend. Sometimes we'll recommend an even tighter threshold. And there are guidelines for how to keep a certain kilocalorie diet, unless you're a marathon runner or a heavy swimmer. I mean, we will recommend keeping an 1,800 kilocalorie diet or a 2,000 kilocalorie diet for most of our diabetic patients as well.
Wait, you mentioned swimming in particular there?
Well, I mean, I just pointed it out as a category of individuals who will burn an excessive number of calories. So unless you belong to a group of individuals that are burning high numbers of calories, it's important to be attuned to what your own calorie expenditure is. So one of the common, going back to how to reduce your risk of stroke and similarly how to reduce your risk for cardiovascular disease, is important to have a healthy body weight. And one of the ways to have a healthy body weight is to reduce calorie intake. One of the common myths is, how can I burn a lot of calories? Actually, 75% of that is reducing caloric intake, and much less of it is actually burning calories. So take an example of breakfast foods, right? Well, a lot of people don't eat breakfast, which is probably a big problem, right? So then you make it up with an excessive intake at lunch and later in the afternoon, later at dinner, and injudicious intake, either of choice of foods and quantity.
Injudicious. I like that.
I mean, we've all been there, but
I've been there.
Yeah, no, and so have I. But the problem is that it's really hard to catch up with appropriate getting back on track, right, with the quantity of calories and the quality of where you wanted the day to go. So starting off with a good breakfast and setting the day right so your body doesn't go into starvation mode and secrete insulin or these fat storing hormones, and just so that your body feels free to burn calories and actually go into just weight loss mode all day. So I recommend that most of our patients who are attempting to maintain a healthy body weight eat 3 to 5 meals per day with healthy snacks, not high calorie meals or high calorie snacks as much as possible. And as far as the choice of what they're eating, say, if we pick a choice of foods for breakfast, think carefully before you pick an item. If you're looking at a muffin, for example, unless this is something that you personally have made and you know what is in this, if you pick one of the commercial items, a lot of the muffins out there will be 400 to 500 calories, which is, you're looking at 4 to 5 hours on a treadmill, unless you are running up an incline, at 3 miles or 4 miles an hour. So that's not realistic, right? It's generally not worth it. And more importantly, it's not realistic. So I think people don't think that way when they are planning what they eat, particularly if it's impulse eating. So anyways, that's just an example of how you want to flesh out decision making.
Well, so what you said there about your body feeling free to burn calories is really interesting, right? Because you need, that's a revelation for me, because if you don't have enough food in your body's going to hoard calories, right?
Absolutely.
Okay. So you've got to just let it know that, look, food's coming regularly. You don't have to hoard this stuff.
Right. Your gastrointestinal and your endocrine system does not think according to the brain. It releases hormones in accordance to what is coming in. And if nothing is coming in, it is not going to secrete glucagon. It's not going to secrete hormones that is going to burn calories. So the hormonal secretions of those people in starvation mode is very different than those of individuals who are regularly getting calories. And your metabolism goes up every time you eat. And so when you're not eating, the metabolism is down. That has to be balanced with regular physical activity, hydration, etc. So, it is always a balance.
What is the risk, especially with alcohol and stroke?
There is a J-shaped curve with the risk of alcohol abuse and stroke, or I should say alcohol use and stroke. It seems to be that teetotalers have slightly higher incidence of stroke, and as in cardiovascular disease, so too with cerebrovascular disease, that moderation is key, and binge drinking is associated with higher risks of stroke, particularly hemorrhagic stroke. So moderation is important, and no alcohol intake whatsoever is associated with a slightly increased risk of stroke and excessive.
Is that, when you say J-shaped curve, what do you mean?
What I mean is that if you picture a J on a graph,
okay,
and the incidence of stroke is a little bit higher in those who don't drink at all, is lowest in those who drink in moderation. So 1 to 2 drinks per day, particularly in women. So 1 drink a day, then 1 to 2 drinks a day. And it goes up from there as far as incidence of stroke if there is binge drinking. The risk of hemorrhagic stroke is particularly higher with binge drinking. The risk of ischemic stroke is also higher with excessive alcohol use.
Why is that? What is the mechanism?
There's so many reasons for this. There's free radical formation, microvascular injury, leaky membranes, coagulopathy due to liver injury, accumulation of cerebrovascular disease. There's a variety of mechanisms by which injury occurs, but it's both ischemic and hemorrhagic stroke.
When binge drinking is not what we think, right? It's lower level drinking than you think of binge drinking. Is that right?
Right. I think the binge drinking term is not well understood by the population. So, a lot of the population that doesn't drink during the week and goes out and has 5 to 7 drinks on a weekend night, they don't think of themselves as binge drinking, but that is a small binge, right?
Yeah.
So that's the kind of behavior that on a regular basis increases the risk of cerebrovascular disease.
I don't know if you saw it. There was a piece in the New York Times this week about walking. And according to the Times, walking is like a miracle cure. You don't think about it being, you think about, you're not running a marathon, you're not pumping a lot of iron, you're not, but it is apparently good for almost every part of your existence. Exercise, cognition, all of these things. And I imagine it's activity. It's probably more rigorous activity than we think. And it probably fits into this. I imagine it fits into the kind of lifestyle you'd want your patients to have.
Well, I would agree with that. And I think one of the insidious aspects of how walking benefits individuals over their lifespan is that it's so easy to do that it tricks people in the sense that you don't even realize that you're getting a health benefit over time. It's how steps add up, right? A lot of times people lug themselves to the gym after a great mental effort in preparing themselves to do a 30 or 45 minute workout. Whereas if it just came to 5 to 10 minutes of walking here or there, they can do it, right? It's about getting a little bit done. And that's it. If it was just about 5 to 10 minutes of walking and they didn't think of it as a mental preparation for a workout,
right,
they could do it, right? And that's particularly important if you are recovering from a major illness or a stroke, and or you are trying to get your life on track and you don't have the energy or you don't have the time for a complete 100% perfect workout, but you could fit in a 5 to 10 minute walk. So it doesn't have to be.
You know, I had a friend who got a dog and he lost 30 pounds.
That's amazing.
Because the dog has to be walked like 3 times a day because it's a collie. And yeah, he looks completely different. And he didn't join a gym. He didn't, you know what I mean? He just started walking all the time. Not to shift gears, but a little bit here, but what do people do who live in rural areas away from the health apparatus that you have, like in LA or I have in Portland, where they can get to care quickly if they have a stroke? I mean, if time is brain, how does this happen in rural areas?
Yeah, so I still recommend that when patients or family members note the first sign or symptom of stroke, they still call 911 because for multiple reasons, you may lose the ability to activate emergency medical services later as the stroke worsens or as patients lose their faculties or strength or ability to access telecommunications. So they should be taken to their nearest competent facility. And I say that from the standpoint of there are different levels of healthcare facilities that can handle readiness to triage and treat stroke patients. And those levels are acute stroke ready hospitals, primary stroke centers, thrombectomy capable centers, and comprehensive stroke centers, depending on their ability to offer thrombolytics, to perform mechanical thrombectomy procedures, and then to triage, treat ischemic and all types of hemorrhagic stroke patients 24/7 with a neurocritical care unit, with all the facilities and with all the specialized care providers. But they should go without losing time to their nearest facility that EMS can take them to, unless there is one or unless there is a second facility with a higher level of care that will not delay them more than 15 minutes. And EMS will know that. Their local EMS should know that they would call. And so that's the importance of calling 911 and not relying on local physicians or local resources, family members, to bring them to the hospital.
It sounds like in any case, no matter where you are, if you're, in downtown LA or you're, in the middle of Montana, knowing the signs of stroke is key.
Right.
So should we just review those?
Absolutely. Yes. So it used to be that on billboards, the radio, in print, we would ask them to go by FAST, face, arm, speech, time. But then we recognized that we were missing a couple of key features, such as balance and eyes. And so now we go by BFAST. So that's balance, any signs of imbalance or incoordination that might represent an issue with the posterior circulation, the vertebrobasilar arteries. So eyes, is there blurry vision? Is there loss of vision? Is there double vision? Face, is there one side of the face drooping, or is there an asymmetric smile if you ask them to smile or grimace? Arm, you ask them to hold their arms out, ideally palms up, and you see, is there any drooping or drifting, or one arm can't even be lifted? Speech, is their speech slurred, or they can't talk, they can't understand you, they can't get the words out? And the last is time. So time is to call 911.
So give me the acronym again.
BFAST.
B-E?
BEFAST.
Okay.
BFAST.
Easy.
Yes.
Okay. All right. Because that's key. If you don't know what's happening, you're going to lose time, no matter where you are.
What's important is that patients and family members, because family members are key. A lot of times, patients aren't the ones who are able to identify the signs and symptoms of stroke because they are involved in the stroke process so intimately that they are not able to identify the stroke happening in themselves. Family members are key to recognizing the signs and symptoms in their loved ones. So they have to be the ones to call 911, calling other family members, calling other physicians, calling the hospital, bringing the patients themselves to the hospital is only going to result in delay the majority of the time. So the perception of we'll wait this off, we'll give an aspirin, we'll bring them into the primary care provider's office on Monday morning. There's a lot of denial that happens with stroke that doesn't happen with heart attacks, right? Heart attacks are a little more homogeneous, right? Crushing chest pain. It's more mainstream. It's more common, of course, right? So there's some denial that happens with stroke. There's some shame associated potentially with an ambulance showing up and having the neighbors see. There's financial concerns. Is this going to cost me out of my pocket? Any number of reasons why people do not want to call an ambulance, but it's a life-saving decision to have stroke patients brought to the ambulance. And studies have shown that if you come in to the ER saying, my wife's having a stroke, please take care of her, versus coming in with through the bells and whistles approach, those patients are the ones that are likely.
What's the bells and whistles approach? What?
The ambulance having,
okay.
Right, with the paramedics bringing you to the emergency department and having the paramedics give the history. And also you have a head start, right? They're able to triage, they're able to apply BFAST to themselves and give a heads up to the emergency department physician and say, this person has a facial droop. They're paralyzed on the right side. The last time well for this patient was, 5:00 this morning when, the spouse saw them going to get coffee. Then they found them on the floor of the bathroom with garbled speech and paralyzed on the side. These are the medications they're taking. They are a candidate for getting a thrombolytic. And they have the full history. They make the job of the emergency department team and the stroke neurologist, the neurointerventionalist, much easier. They're handing the history and the physical examination to the emergency department physician and nurse. They've already got IVs established. In many cases, they've got a blood sugar. They've got an EKG sometimes. They're making the job much easier. These patients are whisked to the CT scanner and statistically significantly more likely to get thrombolytic medication and mechanical thrombectomy and survive their hospitalization than patients who come to the emergency department through their own devices.
Yeah. So, you described, I had a relative who had a stroke. And he was like, I'm fine. It's nothing. Just like you said. And it was his wife who said, you're having a stroke. You are having a stroke. She knew. He didn't, right? He was in denial. And she called 911 and it was fine. He was fine. But you just nailed it. That's exactly his experience, what you just described.
Yeah, it's challenging because most strokes are painless unless they happen to be hemorrhagic stroke. Blood in the brain is very irritating. And so those will often present as severe headaches, sometimes the worst headache of one's life. But most ischemic strokes are painless. So that also contributes to the perception from the stroke patient standpoint and maybe the family member standpoint that this is less serious than it is because there's no pain involved, unlike a heart attack in which there's a lot of pain involved.
Fantastic. This is great. I think this is going to be super useful. Dr. Narayanan, thank you so much for joining us, and we'll do this again.
Thank you so much.